Hello, my name is Karen Tritz. I'm the Director of the Division of Nursing Homes in the Survey and Certification Group at CMS. I'm very excited to be talking with you about the interpretive guidance and a bit about the upcoming long-term care survey process changes. We are releasing revised interpretive guidance to implement the new requirements for participation and to update those areas of prior requirements that needed clarification or updates. We encourage everyone to look closely at what is new and the scope of changes. First, there is quite a bit that hasn't changed. Most of the minimum quality standards that were in the regulation remained. There are still strong resident rights, use of the minimum data set to do assessment and care planning based on the residents' goals and preferences, and the input of the interdisciplinary team. There are still requirements for a medical director, a full-time licensed nurse, and requirements for medication review. These are just some of the regulatory requirements that will be familiar to you. There are some key pieces that are different, and we want to make sure that we highlight some of these changes. We have identified 10 topics that will provide short highlights from Division of Nursing Home staff who have been working on these sections. We address several key components, including person-centered care, admission, transfer, and discharge, abuse and neglect, quality of life and quality of care, pharmacy services and psychotropic medications, facility assessment, sufficient and competent staffing, behavioral health, Q&A and QAPI, infection control, and antibiotic stewardship. These will cover some of the main regulatory groupings. It will also include certain FTAGs and changes. It can't cover everything, so we will also be providing additional slide handouts summarizing changes for those regulatory sections and topics not covered through videos. In this video, I'd like to talk specifically with you about the updates to the structure of Appendix PP. As the revised requirements for participation were being developed, we knew that updating Appendix PP and incorporating the new regulatory requirements and the new FTAGs would be a key component of the work. We also wanted to take this opportunity to get feedback from a variety of stakeholders on various aspects of Appendix PP, what they found helpful and clear in determining compliance, and what was not as helpful. So we did a survey monkey of surveyors and talked with a variety of groups to get feedback on what sections of Appendix PP they found most helpful and what tags could be improved. There were a couple of general themes that emerged from the feedback. One was to try and keep all of the relevant information for a given area of compliance in one section so that there wasn't a lot of cross-referencing. We also heard that surveyors really appreciated having the deficiency categorization as examples. So in making our updates, we kept all of this feedback in mind and also addressed issues not previously discussed, such as the use of personal alarms. We also got feedback from a wide variety of stakeholders throughout the process. Our general approach was to tailor the sections based on the regulatory language itself and the level of complexity. So, for example, in areas where the facility takes actions to prevent a pressure injury, that's a more complex topic than, for example, posting of staffing information. So the guidance has more information related to pressure injury, including an intent and key elements of non-compliance section, versus posting staffing information, which is more straightforward. So I'd like to spend the next few minutes talking with you about some of the main differences in the interpretive guidance in terms of structure and format so that you have some context for understanding. First, you'll see all new FTAGs. The new regulatory changes required a reorganizing of the tags. We are starting at F545 and going through F949. There were lots of reasons we chose to renumber, and we know it is a lot for all of us to get used to, especially since we have many of the old FTAGs committed to memory. However, the upside is that anytime you see an FTAG above 545, you'll know it's the new regulatory set versus the previous regulatory set. As before, you'll also see the regulatory citation and the exact regulatory language in bold. The first section is intent. The intent offers additional information and key context for the regulation. What is the purpose? What is the intended quality issue that this addresses? The second section is definitions. These definitions come from a couple of places. In some cases, they come directly from 483.5, which is the definitions section of the regulation. In other cases, we added definitions that are relevant for that regulatory section. So, for example, in the admission, transfer, and discharge interpretive guidance, we define facility-initiated discharge versus a resident-initiated discharge. We've added this definition because it is important to understanding compliance with that particular requirement. The next area of guidance, interpretive guidance, is the guidance itself. This section is the primary component where CMS describes what is compliance with that particular section. We may reference important concepts related to compliance, may establish frameworks that allow facilities to think about different aspects of compliance, and reference standards of practice. As a reminder, surveyors must cite to the regulations themselves and not to the interpretive guidance. The next area of interpretive guidance is the key elements of noncompliance. This is a new section that we've added to certain tags. In thinking about Appendix PP and what we wanted to keep and change, there was a sense that within all the guidance, we didn't want the key points to be lost, and we didn't want to just restate the regulation. Our goal was to try and summarize the key elements and make it as clear as we could and share with the surveyor what the main points to focus on include. To develop these, in many cases we looked at the case law to determine what was needed and what wasn't needed to have a deficiency. For example, in the area of sufficient staffing, there was the belief that to cite a sufficient staffing tag, that resident outcomes needed to be explicitly tied back to the residents' care plans in all cases. Based on our review, that does not need to be the case, where there are certain basic needs, like perhaps being fed or having assistance with activities of daily living. The surveyor didn't have to have an explicit care plan reference for those areas. Another section of guidance is the investigative summary or probes or protocols section. This section may be called any of these items. The reason that they can be called a few different headings is that this will guide you in understanding whether or not there are other survey documents called critical element pathways or CE pathways that are used by surveyors in determining compliance, which I'll talk more about in a moment. In general, this section is intended to tell the reader how compliance with that section will be investigated or evaluated. There are three sources of information: interview, observation, and record review. This section will describe exactly what would be reviewed if there are concerns identified. First, the investigative summary. In these circumstances, there is a specific critical element pathway or facility task that the surveyor would use to investigate that area. What is in Appendix PP is a high-level summary of that CE pathway. Investigation of subjects like assistance with activities of daily living, personal funds, and sufficient staffing are covered in a facility task or a critical element pathway. In these cases, we refer the surveyor to those documents to avoid duplication and confusion. The next section is the deficiency categorization, and this section is intended to provide examples of level 1, 2, 3, and 4 deficiencies. These are examples to help identify the types of noncompliance that rise to that level of deficiency. This area of interpretive guidance was identified by surveyors as a particularly helpful area for them, so we've added guidance in this area. Level 4 includes immediate jeopardy, which is a serious harm, injury, impairment, or death to a resident. This is either an actual outcome or a likely outcome. We provide specific examples in each tag that would fall under that category. Examples of severity level 3, which would be actual harm that is not immediate jeopardy, and again provide examples of the facilities of a situation where the noncompliance would result in facility noncompliance at level 3. Level 2 would be no actual harm with potential for more than minimal harm. that would not rise to the level of immediate jeopardy, and we provide examples of those severity levels. Level 1 would be A, B, or C. There is no actual harm with a potential for minimal harm. In some cases, depending upon the tag, we have indicated that severity level 1 would not apply for that particular regulatory requirement. These examples are those cases where any level of noncompliance with that has the potential to result in more than minimal harm. The final category that I would like to mention is the potential tags for additional investigation. In this section, when you have finished your investigation, there may be related systems or processes or outcomes that may also have noncompliance. This section identifies the major tags. As a reminder, these are not automatic citations for other areas, and there must be an independent investigation of those tags before cross-referencing. It is not just a copy and paste of the same evidence. Those are the basics of Appendix PP. We will appreciate your continued feedback on the tags and guidance as we continually strive to make these requirements as clear as possible. In addition to revisions to Appendix PP, we will also be updating the survey process to move to a single survey process for the revised requirements nationwide. For additional information about the revised long-term care survey process, please see our website at www.cms.gov/Medicare/provider enrollment and certification, guidance for laws and regulations /nursing homes. I'd like to close with a few final thoughts. This video is part of a broad effort to train everyone on the revised interpretive guidance and the new survey process. While much has stayed the same, there are a number of new pieces that will be taking some getting used to. On behalf of all of us, I would like to express our thanks to the surveyors. We appreciate all of your hard work in understanding and implementing the revised survey process for these revised requirements. We know that these videos are being watched by many. For those nursing homes who may be watching, we also know that you are working hard to understand and implement these requirements from the standpoint of your policies and staffing and operations to meet the various implementation dates. Thank you for all of your efforts. As these revised requirements and survey processes are implemented, many of you may have feedback and questions for us. We welcome this. Please feel free to reach out to us at the CMS mailbox at nhsurveydevelopment@cms.hhs.gov. It is very important for us to understand what the issues are, where there may be concerns coming up, and also where the successes are, so that they can be shared with others. With that, I wish you well. I hope you find the video and training series helpful, and most importantly, thank you for your continued efforts towards our shared goal in providing good quality care to America's nursing home residents.